Once again, thank you for inviting me in drama meeting, Dr. Mohammed Al-Amri, and of course, all of steering committee. I'm very happy to be here and sharing with you, all of you, in this wonderful meeting. My session topic sharing about the lacrimal injury. I think all of us know well about the eyelid structure. There was 7 layers of the eyelid structure that's our landmark like orbital flare. Fat. And in the margin landmark, like eyelids, eyeline, gray line, and meibomian gland. In injury of the eyelid, of course, when during the surgery, we should be open both eyes to know about the symmetrical condition. If we see there is only one eye involvement. And in the medial part, there is interesting on important landmark like lacrimal structure. We know the canalicular line about the 8 millimeters, and there was a lacrimal excretory system. And in our hospital, there was more than 35% case with the canalicular involvement. If we're comparing with all the eyelid injury. The common cause is animal bite, blunt force impact, and penetrating wound. Vulnerable medial portion lacking supporting structure to increase the tensile or pressure force of the elevated of risk of the excretory lacrimal system avulsion. I use the classification of Zhang. There, he divided into lateral, central, and medial part of the lacrimal injury, especially in the canalicular. To know is very easy. Maybe we can find if is it the laceration only in the central or the lateral part. It means it's near from the punctum. We know the length of the canalicular is 8 millimeter. Usually in the medial part, it's more difficult to find it, but using the microscope, I think is mandatory for reconstructive the eyelid eruptor, especially in the canalicular laceration. Of course, in case with trauma, emergency life-saving is important. After that, maybe we can have a history-taking evaluation, how the mechanism, timing, and location. And the canalicular laceration are identified by direct observation. Of course, we can look at the slit lamp, and is there any laceration of medial punctum? Then we can put the probing with a Wolman probe, or we can do the irrigation with canalicular. But in the severe condition, we cannot do it or exploration before the surgery in the slit lamp, but we can do it in the during surgery in the operating theater. For diagnosis study, in the lacrimal injury, like canalicular, we can perform the lacrimal scintigraphy after the surgery is done, that we can know is it the pump of the lacrimal work and the canalicular already reconstructed well or not. And then the diagnostic study like CT scan, I think is important to know if there is any involvement of orbital fracture. This is some video that I can show to you. I think in the canalicular, it's more easy if you use a mini monoca stent, because there is a plug up there and prevent the extruding. Yeah. After we put the mini monoca, and then we can suturing surrounding the tube. That why more easy to use it vicryl, and after that we can suturing the eyelid, the margin of the eyelid. And this one is a little bit similar. This is in the inferior. Yeah. If we don't know where is the edge of the canalicular, we can do the syringing, put the irrigation, and then after we make sure the distal of the canalicular rafter. This is a little bit medial part from the classification of Zhuang, because the length is the rupture is more than 8 millimeter. That's why sometimes it's difficult to look at the edge of the canalicular. That's why we should make sure it with the syringing first, and then after we sure that we can put the canal mini monoca and then suturing around the canalicular with vicryl and suturing the eyelid margin. Okay. Sometimes if we don't have a mini monoca, we can use bicanacular repair also. It's not so difficult, but I think we can put inserted the silicone not only in the lower part that injured, but we can put the silicone in the upper eyelid. This one. Yeah, I think this is a similar. This is more easy because this is a lateral from the classification of Zhuang. It's less than 4 millimeter from the punctum that we can find more easy. Then the distal, sometimes we can use the tip with the adrenaline to know the calamari ring for the edge of the canalicular. And then we can put the silicone in the lower and upper for fixation. Sometimes we can use the pigtail probe, but I think using the pigtail probe, we should be careful because sometimes we have a difficulty to use it. Sometimes it can make it the disrupting of canalicular more severe. And in case, another case with 57 years, 1 minute, and we have a patient with lacrimal injury involving naso-orbital ethmoidal fracture. I think in case like this, I think it's very important we do it in the first time. And I mean, in emergency case, when we look, there is any lacrimal and laceration with the naso-orbital fracture. I think using the technique, and then we did like a DCR, external DCR, because the medial part of the lacrimal bone is already disrupted from the trauma. That's why I think in the first case we did the surgery for the lacrimal system also. Then we suturing the tunnel and then the fixation for the fracture, the medial fracture, and then repositioning the medial canthal. Okay, thank you. I think for me, I would like to invite all of you. We have a meeting in Bali, Asia Pacific ophthalmic trauma meeting that will be 1 month later in November in Bali. See you there. Thank you very much for your time.